SOC 311, Project Plan, Part D for Ray Thompson. Disproportionate health conditions amongst Indigenous Australians compared to non-Indigenous Australians remains prevalent, particularly within remote communities in Australia. Poor nutrition is a major contributor to health issues such as being overweight, chronic diseases, malnutrition, which includes overnutrition from high consumption of discretionary foods, or undernutrition due to dietary deficiencies, and various heart diseases, including cardiovascular disease. Cardiovascular disease and other chronic diseases are liable for approximately 75% of the mortality gap between Aboriginal and Torres Strait Islander Australians compared to non-Indigenous Australians. In 2017, heart disease alone accounted for 12% of Aboriginal and Torres Strait Islander deaths. Additionally, it is expected that Aboriginal and Torres Strait Islander people born between 2005 to 2007 will die approximately 11 years younger than non-Indigenous Australians. The total burden of disease for Indigenous Australians is a 9.7% contribution through dietary risks. In terms of death rates and the cost of health care, cardiovascular disease is considered the most costly disease within Australia, highlighting its importance as a national health priority. Influential determinants of the inordinate health issues faced by Aboriginal and Torres Strait Islander people include lower educational opportunities and therefore higher rates of unemployment and lower income, lack of access to quality healthcare, inadequate and overcrowded housing arrangements, poor infrastructure, and a general loss of power over policy choices regarding their health and living arrangements. Leading causes contributing to the health inequality of Aboriginal and Torres Strait Islander people are related to poor diet. These include obesity, alcohol use, substance abuse, high blood pressure and high cholesterol levels, sedentary lifestyles, and lack of nutritional foods. For example, very little amounts of fresh fruit, vegetables, lean meats are consumed as part of a well-balanced diet. Poor diet and nutritional status amongst Aboriginal and Torres Strait Islander people can be related to social and economic exclusion, as well as geographical and environmental disadvantages. Poor nutrition can be determined through food insecurity, especially for those residing in remote communities, which makes up 25% of the Indigenous Australian population. Food insecurity is a major influential factor towards Indigenous Australian disease risk factors. Underlying causes of food insecurity include a lack of demand for healthier food options, inadequate supply of nutritious and quality foods such as fresh fruit, vegetables, lean meats, whole grain products and low-fat dairy products, remoteness, limited choices, and poor infrastructure within remote communities. In addition, availability, accessibility, and affordability of nutritious foods is a concern for Indigenous Australians residing in remote communities. Low income and unemployment status can affect food insecurity. On average, a weekly gross income for a non-Indigenous Australian is $250 less compared to non-Indigenous Australians. Low income and unemployment status can affect food insecurity. On average, a weekly gross income for Indigenous Australians is $250 less compared to non-Indigenous Australians. Household incomes and food prices play a major role in affordability of nutritious foods, and it is estimated that a healthy diet governs 34 to 80% of disposable income for Indigenous families living in remote communities, which is at least twice what is required by non-Indigenous Australians residing in urban areas. Furthermore, there is limited food supply within remote communities, often having one general store that is only accessible during certain hours. Within remote communities, average costs of fresh produce is 30% more than in urban areas, and nutritious food baskets are estimated to cost up to 50% more compared to major cities. It is reported that from 2011 to 2013, 22% of Indigenous Australians surveyed expressed they had run out of food with no money left to purchase more, even more likely in those residing in remote areas than non-remote areas, which is a 31% to 20% respectively. A staggering 97% of Indigenous Australians aged 18 years and over stated an inadequate consumption of fruit and veg, more so within those living in remote communities. Lack of nutritional knowledge at a community level is evident within Indigenous communities, shown through dietary intake estimates. Methods used to determine food habits include the store turnover method, which uses barcoding scanning in order to document which products are being sold. Store turnover indicates little change to dietary behaviour over the last 25 years. A comparison of food habits between Indigenous Australians and non-Indigenous Australians has shown that the convenient foods and takeaway foods are favourable choices of meals consumed by Indigenous Australians within remote communities. Approximately 41% of the daily energy expenditure comes from the consumption of discretionary foods high in sugar and white flour, such as cakes, biscuits and cereal-based foods, as well as soft drinks within these remote communities. The daily sugar consumption within Indigenous Australian communities is around 75 grams, which is 18 teaspoons per day, which is 50% more than non-Indigenous Australian intakes. It is recommended by WHO that adults and children should consume less than 10% free sugars per day. Obesity amongst Indigenous Australians is a major contributing factor for cardiovascular disease. It is reported that in 2012-2013, 39% of Indigenous Australians aged 18 years and over were obese, which is 53% more compared to non-Indigenous Australians. High blood pressure and high cholesterol levels are more likely to affect those residing in remote communities. Blood pressure was 33.9% higher for remote living compared to 32% living in metropolitan areas. In 2012-2013, 3 out of 5 Indigenous Australians were reported to have sedentary levels of exercise, which equates to 61% of the Indigenous population. Other factors affecting the risk of diet-related disease include overcrowding of residential areas and therefore limited facilities in which to prepare foods, deficient knowledge on food literacy, inadequate educational opportunities and insufficient motivation around food practices, including lack of knowledge and skills towards food preparation, storage and cooking methods. Previous community-based health interventions have concluded positive outcomes towards a reduction in diet-related diseases. Successful programs include the Luma Health Lifestyle Program and the Minjilang Health and Nutrition Project. The Minjilang Health and Nutrition Project. The success of these programs can be attributed to the Indigenous community involvement throughout the programs. Community member involvement ensures the programs are culturally tailored to the community members' needs. External organisations have also provided technical and financial support toward the success of these programs. Evidence gathered from various cohort studies has identified that nutrition interventions with Indigenous remote communities have improved health of the individuals and communities as a whole when sustained over several years. Furthermore, there is an overall cost benefit when programs are run effectively through reduced medical costs and hospital admissions. Patterns of expenditure show Indigenous Australians are on average higher users of publicly funded health services compared to non-Indigenous Australians. Furthermore, an increase in patient expenditure is noted for remote community members due to higher costs of service provisions to remote communities. It was reported that over 50% of the Commonwealth financial contribution was used for public hospital funding. The initiation program I am proposing will include several remote communities in Queensland and incorporate the effective and successful strategies used in previous programs, such as the Luma Healthy Lifestyle Program and the Minjilang Nutrition and Health Project. This will call for favourable methods to improve nutrition and lifestyles, whilst reducing risks of diet-related disease within the Indigenous communities. The motivation behind this program is to place a focus on targeting individual and community priorities whilst keeping to traditional methods where possible. This will be implemented through regular group discussions relating to nutrition and the benefits of a healthy diet and lifestyle habits in order to reduce the risk of cardiovascular disease and other heart-related conditions. The program will offer informal classes around the importance of healthy lifestyle and nutritional value towards disease prevention. Weekly gatherings will also cover food literacy, including correct food preparation and storage. Regular cooking demonstrations will be held in the community kitchens to demonstrate how to prepare nutritious meals using fresh produce, lean meats and traditional bush foods whilst promoting traditional methods. Based on evidence, cooking classes and food literacy discussions have shown improvements for community development, empowerment and self-efficacy, and reduced social isolation. Store tours will be run several times a week to enhance the community members' knowledge around food security and to help improve shopping and budgeting skills. Furthermore, informal conversations around budgeting will also be incorporated, which will help raise awareness around dietary behaviours, increase confidence amongst community members, and help overcome nutrition-related inequalities. Nutritional education alone won't correct food security. Therefore, combining this with other health approaches will help improve on the overall success of the program. The program will help address food security and provide additional food supply through community gardens within the community centre, residential dwellings and schools. The gardens will allow further access to fresh produce while providing the opportunity for social interactions. The school-based gardens will increase a positive attitude towards healthy values amongst younger generations. Research has shown that for optimum results, improving health promotion and to better manage poor nutrition amongst Aboriginal and Torres Strait Islander people, additional and ongoing support is vital. This includes management from Indigenous community members, nutritionists, specialists and allied health workers and government agents all working together. Additional resources through public health services and nutrition actions, as well as government and education services, should be employed for success of Indigenous Australians and cardiovascular disease prevention. Reviewed evidence of community-based health interventions have justified the use of funding towards the action of diet-related disease prevention. This includes whole health continuum, which necessitates public health policy action and the promotion of improved nutrition. In addition, without adequate and ongoing funding, sustainability of these programs will be challenging and more likely cease. The goal of my program is to reduce cardiovascular disease amongst Indigenous Australians living in remote communities by 30% within 15 years. This will be achieved through addressing diet, health and social aspects. Objective 1. Develop healthy attitudes surrounding nutrition and lifestyle factors amongst Indigenous communities in order to reduce cardiovascular disease and other chronic diseases that contribute to premature deaths of Indigenous Australians. Strategy 1. Regular education classes and discussion groups amongst adult community members and in schools in order to educate children. These groups will encompass healthy behaviours towards food and nutrition to help reduce the risks of food-related diseases. Objective 2. Reduce food insecurity and other poor habits that contribute to cardiovascular disease, such as obesity, smoking, alcohol consumption and substance abuse amongst Indigenous communities. Strategy 2. Discussions on budgeting for nutritious foods and choosing healthier foods on a low income through store tours. Discussions on lifestyle factors such as smoking, alcohol consumption and substance abuse and how these can affect one's health, and exercise groups such as walking in order to combat obesity. Objective 3. Increase long-term awareness of food handling, including food preparation, correct and safe storage of food, cooking wholesome meals, and expanding general knowledge around food literacy. Strategy 3. Programs to support long-term sustainability of health and nutrition, including building and maintaining community gardens and cooking classes demonstrating healthy food choices and traditional methods. In order to evaluate the progression of the program, certain practices will be followed. These include a process evaluation, an impact evaluation, and an outcome evaluation. Evaluation plans will comprise of both quantitative and qualitative methods. Firstly, process evaluation. Quantitative methods include screening for cardiovascular disease and calculating absolute cardiovascular risk each month. BMI and hip to waist circumference checkups each month will also occur. Store turnover data access to determine the actual community dietary intake of sugar, discretionary foods including sugar, white flour and cakes, etc., and amounts of fruit and vegetables purchased each week. Qualitative methods will include individual nutritional health assessment and feedback on personal achievements weekly, and a 24-hour food recall to gain dietary intake once a week. Impact evaluation. Local evaluation governance, including individual reflections on a weekly basis towards the value and participation of the evaluation process once a week, will be qualitative. Qualitative method. And finally, outcome evaluation will be to repeat each of the above monthly. Thank you.